Welcome, everybody. Thank you for being here today. We're going to do a little bit of housekeeping. I'll give a chance for everybody to come on. If somebody would not mind saying hello back in the chat box to make sure we're broadcasting, that would be super helpful. Zoom is pretty bulletproof, and we're pretty sure we're broadcasting, but if you wouldn't mind just saying hello back. Thank you, Anurag. So welcome, everybody, and thank you for sharing your time here on a Monday afternoon. We have a friend in India, Anurag, who has kindly introduced us to this opportunity, and we've had a really interesting time learning more about what's going on, and I'm sure you'll all be quite interested in learning more, and it's fascinating and life-changing and life-saving information. Full disclosure, as often is the case, I have no skin in the game here as an investor, but I'm super keen on helping Dr. Thubrikar out and Anurag talking about and getting this product to market. You're going to learn that there's a similar product that's already been used many times, and we'll be discussing that in detail. If there's anybody that you would like to have join in, please feel free to share the link for this call, and we will be recording it just for the record and putting it up on the Family Office Insights YouTube channel. So a little Zoom housekeeping. We're going to, again, be recording this, and you're most welcome to ask any questions in the chat box or the Q&A as we go along here, and we'll get to them, and I encourage you to do so. The information is and background is also available on the Family Office Insights Peer Insights report, where Dr. Thubrikar has did a bit of a Q&A, and his information is there for contact information as well as Samir, who has just joined us. So with that, I'm going to ask Dr. Thubrikar, I'm going to do that right soon, to introduce himself and then go on with the formal presentation. So thanks everybody for being here, and Anurag, thank you again for introducing this fine opportunity to the Family Office Insights community. Welcome. Go ahead, Doctor.
Greetings, everyone. This is really a pleasure for me to have come across Anurag, and also for Anurag to have introduced our company to Arthur, and then for Arthur to bring us to you. It is a pleasure to be talking to all of you. I was born in India, became a citizen of US several years ago, but many years ago, I came to United States to do master's and PhD, which I did at New York University. I did a PhD in biomedical engineering, and one of my advisor was a head of rehab medicine at NYU Medical Center. So I have had many years of association with New York University Medical Center, and interestingly, full circle now, after many years of gap, I'm connected with the TAVI physician in New York University. So that is very interesting coincidence. After the PhD, my first job was at University of Virginia in Department of Cardiac Surgery, actually. So I was a biomedical engineering PhD person working with surgeons, surgery residents, and the entire engineering school and medical school and the graduate students and so forth. So I was like a typical professor scientist in the university setting. I spent many years in the University of Virginia, and we did years and years of research just focus on the aortic valve because the heart valves surgery were coming around in those years, and surgeons had a great desire to learn about aortic valve, and so our group became known around the world as most knowledgeable group in the aortic valve because we among very few people in those years in the world, we were very focused on studying aortic valve, and we were generating tremendous amount of data on the aortic valve, which was very nice. And everyone, surgical community, bioprosthetic heart valve community, like the companies, everyone appreciated the knowledge we were creating and the contributions we were making to the knowledge of aortic valve. Subsequent to UVA, I went to Carolinas Medical Center in Charlotte, North Carolina, again in the Heart Institute, continued the research there on aortic valve and on coronary artery disease. It would so happen in those times that I was destined to make a career change and basically go into actually making a heart valve because I was so knowledgeable, or our group was so knowledgeable. So I actually left the university, went to the company to make a heart valve, and I was at Edwards Life Sciences company for about 3 years, 2.5 years. And then I left the Edwards Life Sciences, went back to the academics again. And I joined as a director of biomedical engineering program at South Dakota School of Mines and Technology. And that is where I created a heart valve. And then I knew that in the university, the project lives and dies in the lab. So for the heart valve to see the clinical application, I actually left the university and started my own company, and here we are. So the heart valve I made, it is a transcatheter heart valve. Now, the transcatheter aortic valve replacement, or also known as TAVR or TAVI, aortic valve implantation, TAVR or TAVI, this is a big deal for all of us because every single year there are like 300,000 patients with severe aortic stenosis disease. And a lot of these patients would not survive if they did not get the valve replacement. So what happens is practically everyone who is eligible for surgery goes to do a open heart surgery and get a valve replacement. But somebody about 20 years ago thought of why not put a valve in the catheter and avoid the open heart surgery. So they came up with an idea of transcatheter valve, and they created a company in Israel way back then. In 2004, for the first time, Edwards Life Sciences actually purchased the Israeli company. Now, mind you, in the US, there were 3 companies that were supplying surgery heart valves to the whole world. Now, the Edwards buys a catheter valve, and the rest of the companies are sort of waiting to see what happens to Edwards. So they find out after 5-7 years, oh my God, the transcatheter valve is becoming more accepted, more popular. People don't want to have surgery. They just want to have a transcatheter valve. So what happens? Then other major companies jump on a bandwagon and they start buying other startup companies right and left. And I'll show you a little bit more about that. But the gist of it is that in Europe, in 2007, the first transcatheter valve got approved, and then they started placing thousands of heart valves in Europe. In United States, the heart valve got approved in 2011, and since then it has been accepted and used so widely. So the transcatheter valve is now completely accepted and a routine procedure, and every major center, whether it is NYU, Columbia University, University of Penn, University of Virginia, you name it, every major surgery center, Cleveland Clinic, Cedar Sinai, Los Angeles, Utah, you name it, every major center does the transcatheter valve procedure. So everybody knows, oh my goodness, heart valve surgery is just going to disappear. And it's going to be a revolution just like the stent. When the stent came for coronary artery, the bypass surgery pretty much vanished. And only small percentage of it is getting done now. Huge percentage, like 90, 95, 97% is done by the stenting. So everybody expects the catheter valve to do the same thing. But what has happened is that in the stent, you didn't have to worry about the durability because this was just an open tube. In the valve, the durability has become a big issue. The reason is very obvious. The older patients are the ones who adopted to catheter valve right off the bat. They were not eligible for surgery, so they got it. Well, later on, everybody wanted it, but surgeons are refusing to release the patients. And the reason is very simple. They say, show me the durability. If your valve doesn't have a durability, if it's going to fail in 7 years, and I have a surgical valve that can last this person 15 and 18 years, why would I release a patient to you? So now the turf battle, the cardiologists are trying to take the patients from surgeons, but the surgeons are concerned that they would love to release it because it saves patient open heart surgery. But surgeons are not willing to give the patients because they need to see the proof that the valve has a durability. So when we started our company, it was really strange for me because I was an academician studying aortic valve for many years. What I was seeing is the transcatheter valves, one look at them and they would not look right to me. Not a single heart valve looked right to me. Whether it was Edwards Life Sciences heart valve, Medtronic heart valve, Boston Scientific heart valve, no matter whose heart valve it was, I was totally puzzled. How can they be making a valve that looks like this? I didn't like the idea that they were making a valve that had obvious flaws. Obvious flaws. A high school student could say that these valves are not going to be the best for people in the long run. But they are the ones that became popular because surgery ineligible patients, they had no hope. So they accepted that. And so we have a huge market, but the market has now come to a stop sign. Even though all these centers are doing the TAVI procedures, they are all stuck also at the not having a durable valve. So we need to get going with the durable valve. So our message, our company is saying that we have a durable valve, and that is what is going to change the history of this transcatheter valve. So with that, I want to start getting into the next set of slides. So as I mentioned earlier, I founded the company. I also invented the valve, and I wrote a book called The Aortic Valve back when I was at University of Virginia. We have developed a durable valve, and we also have two most experienced US TAVI physicians as part of our company. They are our medical advisors. the market acceptance for us. Now, the market acceptance for TAVI, I already told you, every major center in the US is doing TAVI right now. And so for our company, we already have two licensed partners, one from Brazil, one from China. They want to manufacture our valve. They want to do the clinical trial. They want to sell our valves. So we indirectly, you can say we are sort of set, except that we have not extended the license to them to sell it in Europe or to sell it in America. Their license is limited only to selling to South America and China. And the reason is we want to be able to sell in America and Europe. So you can see that the licensed partners are anxious for us to extend them their license so they can sell it all over the world. But we are telling them, just hold your horses. We want to be the one to go to Europe and go to the US. We have raised $7 million already, and the two licensed partners are also our biggest investors. Our value proposition is really simple, similar to what I said a little earlier. Younger patients, every single patient wants catheter valve. They do not want open heart surgery, which is obvious. But the younger patients are not getting the TAVI valve because they don't have a durable valve. And funny thing here is, think about this for a minute. If I'm Edwards Life Sciences or I'm at Medtronic or I'm Abbott and I have made a surgical valve and I have made a catheter valve, all I have to do is to produce a proof that here is a surgical valve, here is a catheter valve, and they have a similar performance. But not a single company is able to do that. And the reason is they missed a boat in the critical part of technology. They did not create the catheter valve the way they created a surgical valve. And so they don't have a durability, and that's the issue. So younger patients, when we add younger patients with our technology, we are adding $4 to $6 billion annually to the current market, which is already at $4 billion. But the market needs a durable valve. Our valve has a preclinical history of durability and can easily add 7 or more years to patients' life. We have also proved this in clinical observations by having the clinical implant done in Brazil, and now we have 3 patients with the device success. Our proposition to you for ROI is you will see that TAVI has been such a big revolution that there has been a frenzy of acquisitions in last 10 years. And these acquisitions have ranged from $155 million to close to $1 billion. We estimate ROI to be in the range of 5 to 10, if not more, in a matter of 1 to 3 years. But we need to do the European implants. And for that, we are seeking $8 million for the European trial. The TAVI, or Transcatheter Aortic Valve implantation technology, is like this. You insert a catheter in the leg. That catheter has a valve in it. You carry the catheter through the aorta all the way around the aortic arch in the place of the heart valve. When you bring the valve in the place of the heart valve, you release it and it just sits inside the old valve. So the new valve, you see this is a top view, new valve sits inside the old valve. So nothing from the patient is removed. And so all you have done, insert a catheter, release the valve, take the catheter out, and you are done. And what a difference you can imagine. What a difference in an open heart surgery versus this procedure. Our heart valve and a catheter. So this is our company. This is all we do. We create a heart valve, which is this one here, and we build a catheter, which is this one here. So this heart valve is about little under 1 inch in diameter and under 1 inch in height. Then we compress it. When you compress it, you can put it inside this capsule. The capsule is size smaller than a pencil. And this capsule is then inserted in the leg, and all that catheter goes inside the body. Then the catheter brings the valve to the position of the old valve, and then this handle, by threading mechanism, you just deliver the valve, and our valve comes out like an umbrella, and it just sits inside the old valve. See, our valve is made with a metal called nickel titanium alloy that has a memory to it. It expands by itself. From the capsule, when it comes out and looks like an umbrella. So it expands by itself. And the uniqueness of our valve is it has no suture holes in the flexion zone of the leaflet. So you will see that the suture holes are damaging to the valve function and the valve life. And so we have, see, the technology that big companies had in the surgical valve, when the surgical valves were having a durability, that technology they did not copy in the catheter valve. And now they are running into a big issue of durability because of that. We became aware of this right off the bat. Our valve is designed after a natural aortic valve. And you see the word optimum, it comes from the fact that nature has designed our natural valve in a manner that it is most optimum designed for the valve.
Doctor, can I ask a question?
Sure.
The prior slide, you said that the valve has been proven to extend life 7 years. Is that
7+.
This your valve or the prior valves?
Yeah. So the prior valves now, they have, as you can imagine, different age patients have a different life of the valve, meaning in the older patients, the valve life, not the patient life. The valve life is longer. In younger patient, valve life is less. What current valves have found is they degenerate almost 50% in 7 years. In 7 years. So what we are saying is that our valve will add another 7+ year to it. So we would have a 14 or 16 years of life for which the current valve will offer 7 years.
Okay, that super clears it up because there's the extension of lifespan and then there's the life of the valve. So you basically doubled the life of the catheter applicated valve with your valve. And then suppose that the good news comes about and that the young patient gets your valve, they live 14 years. Do you have to go in and take it out surgically, or can you take it out with the catheter and put a new one in?
Yeah, the good thing about this is, Arthur, that you can actually put another valve inside your own old valve. at the end of 14 years, we could put another valve inside our valve using a catheter, so you avoid another surgery.
Oh, so that's really good news. So Anthony had the question, and I think we just answered it. What is the present lifespan of a TAVR, and why is your valve more durable? So, I mean, you can expand on that, but I think we answered part of that.
Perfect. So this is really where the word optimum is where the university meets the business. As I was saying, if we were to ask a question, a very fundamental question to nature, why does our heart have 4 chambers? And we say, well, all right, as a scientist, let's try to figure out why that's the case. What we did is we asked a question, why is our aortic valve, the natural aortic valve, designed the way it is designed? That was a very fundamental study of understanding the nature's engineering. And we found out that there is a strong principle of physics and mathematics involved. And those we were in our study expressed it in the form of equations. And the nature has optimized the design of our natural valve. And same principles are used in our valve. So the word optimum, we didn't pull it from a blue sky. The optimum word is because the design of our valve has been optimized very much like the design of our natural aortic valve has been optimized. In some sense, one of our investors said to me, he said, Mano, will you be having more generations of valve like improvements? And I said, no, you cannot improve upon nature. So he said, he said, you're saying that the nature has evolved. And that is so true, that the design of the natural valve is, we as a human beings cannot improve what the nature has given us. The aortic valve is located between the aorta and the rest of the body. So the blood flows through this valve to rest of the body. Okay. The narrowing of this valve is called aortic stenosis. Aortic stenosis. And narrowing reduces the blood flow and puts more load on the heart. The severe aortic stenosis, if not treated, can cause death in 50% of patients in 1 year. 50% patients. So once you see a severe aortic stenosis patients in your OPD or in emergency room, you cannot send them home. You have to admit them and perform the open heart surgery. Well, what do you do typically? The typical treatment is replace the valve using open heart surgery. That's what's traditionally done. Well, the TAVI comes along and said, wait a minute, I can replace the valve using a catheter and avoid the open heart surgery. It is no surprise to anybody that it is the biggest revolution in the aortic valve procedure in our lifetime. It is the same revolution like the stent basically eliminated the bypass surgeries. Similarly, TAVI is eliminating the heart valve surgery. However, you run into questions like, okay, TAVI is eliminating all this, but TAVI needs a durable valve to take over surgery for younger patients. Of course, because young patients, if the 60-year-old, you want that person's valve to last as long as that person can go to be 100. So whatever is the max you can offer. So that is the stop sign for the current development of this technology. Even though thousands of procedures are done every single day in the US and in the whole world, it still has run into a stop sign for the younger patients. TAVI was approved in Europe in '07, in the US in 2011, and it was obviously taken up. And it has gradually expanded to other surgical risk profile patients, like ineligible, to a high risk of surgery, to a medium risk of surgery, to a low risk of surgery. And so then you come back and say that, so the issue is current transcatheter valves do not have the same durability as surgical valves. So I'm going to keep the mantra, keep repeating the mantra, durability, durability, durability is where we are. We have created a valve which is at least 2 times higher durability than the current market. Our valve can add 7+ years of life to patient before they go to another procedure, as we discussed with Arthur a minute ago. And this grows the current market. Mind you, current market is already 4 billion, but they are not using more than 50% of the patients. So we can grow the market to 10 billion or more. This is a very important data here. See, the minimum number of patients that are treatable every year currently are 300,000. That's the minimum. There's probably more than that, because this comes from a 10 years old slide. Okay. The surgery ineligible patients, they are all getting TAVI. Sure, why not? Because they don't have medicine doesn't help them so much as the TAVI does. A high risk patient, almost all of them, 12,000 of them are getting TAVI. Well, what about the medium risk? There are about 30,000 patients in medium risk of surgery. What about the low risk? Well, there are about 160,000 patients. Well, these two groups, medium risk and low risk, there are over 150,000 patients in that category, and they are younger than 75. They're younger than 70. I mean, they may be 70, 60, 50, 55. That's the age range completely. They are not getting TAVI. So dominant people that are getting TAVI, they're like 82 years old. So all the people that are under 75, no TAVI for them. Why not? Show me the durable valve. That's where everything is stuck. So the market potential is 10 billion. Well, what allows us to claim we have a durable valve? Well, the test. This is a machine test. Okay. So we run a surgical valve, mind you, not even a TAVI valve. It's a surgical valve. We run a surgical valve for 500 million cycles in the machine. We run our valve for 900 million cycles, almost a billion cycle in the machine. What do we see? We see a tiny damages in the surgical valve, like these holes, like these tears. In our valve, no damage at all. 900 million cycles, no damage. All right. What about the body? Well, when we put a valve in the body, in sheep, for instance, which is also a standard model, standard test, what do you see when you have a surgical valve in sheep? You see these white shadows here. These are calcium deposits, like the bone. So once the calcium deposits gets there in the valve, the mobility of the valve is compromised. It's not flexing, it's not opening, it's becoming stenosed. It's becoming a start of an aortic stenosis disease. That's what these white shadows are. Well, what do we see in our valve? What we see is these little white specks. That's also calcium. But where is that? So the way our valve is made, we take a rectangular piece and we make a cylinder out of it. And then at the end of the that the two edges, there's a seam. At the seam, we have suture holes. So all these specks are really not in the valve, but they are at the seam. And this tells you that the suture holes are a big problem for the calcium deposits. So why is our valve more durable? The reason is simple. It's a superior design, like the optimized design of a natural aortic valve, and it has no suture holes in the flexion zone, because the suture holes is a big problem. And Dr. Leon, who organizes this international conference every year, he made a comment in 2017 that our valve, the Optimum TAV, has a durability you would not believe. We were so happy to get his endorsement. I tell you, that is really super fantastic. Competitors. See, these valves are in practice right now in every major center. The two major competitors have these two platforms, and these two platforms are the ones that have more than 90% of $4 billion a year market right now. Even though they have obvious flaws, that's the other part of it. It's got obvious flaws, but they still have $4 billion market. And the reason is simple. Nobody wants open chest, open heart surgery if they can have a catheter. So what's the issue with this one? See, this valve is made with a material self-expanding, which is the same material we use. Our valve expands by itself. But this valve is very tall. It goes all the way up here. Well, what's wrong with that? Well, it has put the coronary artery in jail. It has caged the coronary artery. Well, what's wrong with that? Well, if this patient comes in with a chest pain and you have to put a stent in it, how are you going to do it? You are going to have to fight to go through this metal frame to go to the coronary artery. That is the biggest disadvantage that is most obvious to us. So why would you design a valve like that? And this is the type of question that haunted me years ago when this technology was just coming up. I said, how could you possibly think of making a valve like that puts the coronary artery in jail? But yet, that's the valve that has billions of dollars of market right now. The second one is this. It's a short valve. So it would sit from here to here. So which means that this area would be open. It's a short valve. So it is not going to put the coronary arteries in jail. It's not caging the arteries. Okay, what's the problem with this? Well, the problem with this is made with a stainless steel metal, like a paper clip or a cobalt chromium metal, okay, which is a very hard, tough metal. Well, so you have to, once you make it small to go in a catheter, you have to then expand it with a balloon. Well, the balloon expansion means you need a big strength to expand it, just like you need a force from your finger to bend the paper clip. So when you expand it, you're using the pressures in the range of 2 to 3 atmosphere. Well, what's a 2 to 3 atmosphere? Well, 1 atmosphere is about 15 pounds. In our car tire, we put 35 pounds of pressure. So this is the more pressure than what we put in our car tires. Well, there's a consequence of that. You are going to be crushing a very delicate tissue between the balloon and the metal frame. So you have to say to yourself, why would you design a valve like that? But yet, that's the valve that has also billions of dollars of market today. And they are our competitors. And we firmly believe that it's only a matter of time before people realize that, hey, you don't have to cage the coronary artery and you don't have to balloon expand anything, because our valve doesn't need a balloon expansion. And so we think that we have incredible advantages over these competitors.
Doctor,
Uh-huh.
now, may I ask a question?
Sure.
So the companies that have the open heart surgery valves that last longer than the present catheter valves, why wouldn't they design, like you have, a catheter valve that lasts longer? And if they did that, would that threaten your company, or is there patents and all that business involved?
Yeah, so that's a very fundamental question. They did not want to get into this arena at all. It was Edwards who purchased a startup company. When the other companies found out that this technology is here to stay, other companies didn't embark on designing the valve. They ran after other startup companies to acquire. Well, so there are two things. These companies do have a knowledge, they can design the valve, but they didn't want to wait for 7 years to get it designed, tested, regulated, approved, clinical trials, and all of that. They wanted to jump on a bandwagon to get the market right off the bat. So one point is they did not want to have an in-house design created. Instead, they went off after the startup company. That's one point. Second point is they could not mimic the surgical valve to begin with because the surgical valve has the sutures hidden behind the cloth. That cloth is what is sutured into the person's heart. And these people didn't want to put a cloth because it would make the valve very big when you compress it. You cannot have a very big valve because if you have a very big catheter, where is it going to go in the body? So they had a limitation on the smaller size catheter you need for the patient, and then figuring out what to do with surgical valve. Our design, we did away with the surgical valve technology of cloth. We didn't want anything to do with it. We simply figured out a way to attach the tissue without having those sutures and attachments in the working leaflet. So we also have the suture holes and tissue attachment to the frame, but it's not in the working valve. And so that's the difference. Now, if they actually go to design it, there is a very good chance that they will have to infringe on our patent. Is that okay, Arthur?
That totally answered the question. Yes, thank you.
Okay. So the clinical validation, we implanted a first patient in December of 2018 in Rio, in Brazil, a female 79-year-old. And the procedure was proctored by our medical advisor, Dr. Matt Williams from NYU. The results, it's phenomenal to see this. I mean, because I was around the bypass surgeries back then, and so I know what the difference is. On the day one, 79-year-old female, on the day one after TAVI, she is walking. On the day 4, she is going home. At 3 months, doing very well. At 12 months, doing very well, has a great performance of the heart valve because you can study the performance of the valve itself. And we had a phone interview with her at 18 months. She's doing great. We will have a 2-year follow-up coming up. And then since then, we have recently implanted 2 more patients with the device implant, quite successful. So this is a revolution. A patient walking the next day compared to open heart where she would be in ICU for minimum 3 days, maybe 5 days, recovery time and everything else that goes with it. Our licensed partners are really, really helpful tremendously to us. We have LabCorp Laboratories of Brazil. They've been selling surgical valves, but they see that the surgical valves is disappearing. So they need to create another business. So now they wanted a license from us for TAVI, and we gave them. Another company in China They wanted a license from us, and we gave them. So these two licenses, they will sponsor their own clinical trial in South America and China. They will commercialize there. And when they commercialize, we will get royalties from their commercialization. Now, I told you a lot about myself, but there's one part I wanted to tell you. Arthur, you have a question?
Yeah, I want to hear about this special part too, but we have a question from Anthony here. Aside from the durability, which is clearly better, are the complications similar or better using your device over the incumbent devices that are being used?
Right. So, from what we have seen in that one patient in a long-term follow-up, we do not have anything special in terms of complications than what is reported in the literature from other people. So you're looking at the stroke, you're looking at paravalvular leak, or you're looking at pacemakers, or whatever other complications you're looking at. These patients are doing very well, and we don't have any issues, not in the catheter delivery system or any of that.
So no worse, no necessarily better. It's the same risk.
Correct. In terms of the competitiveness of how the technology gets inserted and the valve gets delivered, it's very much on par with most of it. Our main thing is durability.
Yeah.
You guys don't have it, and we do.
Yeah. And you can put it in younger patients without open heart. I mean, I think people who are not involved in this sort of thing would easily agree that not being opened up is a good idea.
Absolutely. That the surgeons, the 160,000 patients that would be getting TAVI, surgeons are refusing to release those patients because they say, show me the durable valve. I have a valve. I can make this patient live easily for 16 years. I don't want 50% of them to come back to me in 6 years for a second procedure.
Yeah.
Show me the durable valve. It's really simple, straightforward. And funny thing, Arthur,
yeah.
and funny thing, Arthur, is that in the University of Virginia, all the knowledge we collected, I published a book called The Aortic Valve. You know, many surgeons around the world and many heart valve companies that were very few actually for surgery valves, they all knew me as the researcher of aortic valve, as the writer of aortic valve. That was the reason I named the company after me. I called the company my name because I said people will immediately know who is behind this technology. And that book, that was selling for $100 in 1990. I could not believe 20 years later, it is selling for $500. Why would a book go in price 5 times? It's not a Van Gogh. I don't understand. So it took me a while to figure out it had to be that companies were jumping on a bandwagon to make a valve, but they didn't know how to. And all the knowledge is in this book that they were trying to gather. And that's the only way that book would go up in price. In fact, the other day, the thought came to me that I wouldn't be surprised if a single company purchased all my books to make it disappear from the market.
Yeah, it sounds like a good idea from a competitive standpoint. Yeah.
Yeah.
Okay, thank you. Continue.
So we have 2 medical advisors from the very beginning of our company. As I said earlier, Dr. Matt Williams is the one who proctored our first procedure in Brazil. He is a chief of cardiac surgery, director of interventional cardiology at NYU Langone Medical Center. And then Dr. Sushil Kodali, he is a director of Heart Valve Center at New York Presbyterian Hospital, Columbia University. These two are the most experienced surgeons, the interventional cardiologists for TAVI in the US. They were part of the first trial in the US by Edwards called Partner Trial. They were part of it. Subsequently, they've been part of other trials as well. In the company, we have 5 full-time employees, myself, Samir Wadki, who is a VP of Business Development. Then we have Mark Eberhardt. He's a mechanical engineer. He's a director of product development. We have Evan Rausch. He is an engineer with a biomedical engineering major. He's a research engineer. We have Jason Mattis, who is a lab specialist. Then part-time, we have Dr. Nikhil Heble. He is our patent attorney and IP advisor. And then we have Dr. Vishal Thubrikar. He is my son. He is a cardiologist, and he has been immense help to us in all of our clinical work. Additional board members, we have Dr. Wadke. He has had his career in pharma. Mr. Parate, he is a Wharton graduate. Dr. Tony Zhu from China, he is part of our licensee. And 2 licensees are also 2 major investors in our company. Our value proposition, we have secured 4 patents in the US and 1 in Canada and 1 in Europe. And we believe that the design that is responsible for durability is all contained in those patents. We also have filed a patent for catheter, and we have raised $7 million today. We are seeking $8 million for European trial. And the next 2 slides are very important for you to get your teeth into what we are saying. CE Mark trial. See, most acquisitions in the TAVI has occurred during the European trial, not even getting approval, but during the procedure of getting the trial going. We pose a threat to the existing companies. Now, that's obvious to you by now because they don't have durability. They cannot go to younger patients, and we can. Their valve, there's a data already, their valve is showing reduced durability, so that's of concern to them. And our claim of more durability is based on the gold standard tests, the tests that are accepted by everyone. TAVI growth was incredible in the earlier years, but now it is slowed down, and now actually it has come to a stop sign. Why? Because younger patients want TAVI, but they need a durable valve. So our valve can grow the market. Our Brazilian licensee has been associated already with 1 TAVI acquisition, and they actually want to be our manufacturer and distributor. So think about huge advantage that it means for us. Now, this is something that you would find really, really impressive. What has happened in the history of TAVI? It all started with 2004 when Edwards Lifesciences first purchased an Israeli company for $125 to $155 million. And that company had done only first in human implants, just a few. There was a big waiting period for other companies watching Edwards. And then Medtronic got in panic. And in 2009, they bought 2 companies in 1 week. In 1 week, they bought 2 companies and spent more than $1 billion to buy those companies. In 2011, Boston Scientific got involved because this is an incredibly stable market. Patients are always there, and they paid $225 to $450 million. Then in 2017, Boston Scientific bought another company for $435 million. Abbott acquired St. Jude Transcatheter Valve. So you can see that this has been acquired. because there's a frenzy. This is completely abolishing heart valve surgery. It will be all TAVI. And if we are not getting into the business, we will be left out. And this is an incredible market. Acquirers have needed a clinical data towards European trial. And so we already have begun our work in Brazil. And so when you look at the pricing and when you look at what stage they were and what was their paid, mind you, these are all huge companies, but none of them, not one of them would claim that they have a durable valve and show the data like I did. I showed a surgical valve and our valve side by side. They have the surgical valve. They have the TAVI. All they have to do is to show them side by side. Hey, surgeon, this valve and this valve, they're similar. Surgeon would have no issue with it. But they don't have that data and they don't show that data because they missed the boat on how to attach the leaflet to the frame. And that is their biggest Achilles heel. So this is the last slide. And what is happening here, as you can see, our footprints. See, we already started work in Brazil, as I showed you, and our licensee will continue that clinical trial. In China, our licensee is going to be able to start their trial in the middle of next year. We want to begin with the money we have. We want to begin our implants in Poland first and then in Germany. Why in Poland and then in Germany? Because Germany requires many test reports. Poland requires less test reports. So we think we will get approval to do procedures in Poland before we get approval in Germany. So we are going to be starting our first European implants very soon. We have the money for it. What we are seeking is $8 million to do a full clinical trial towards CE mark. But I have to say, there is no way that we will be allowed to complete a clinical trial in Europe. There's no way. There's so many billions are at stake here that a little company like us, comparing ourselves to the strength of Medtronic or Edwards or Boston Scientific, there's no comparison. There's no way we will be allowed to complete the European trial. But that's the path we want. We want to have our footprints in China, in Brazil, in Europe, and proceed like that. And so with that, I was going to say thank you to all the listeners.
That was extraordinary. Aside from the technology, it was something I could understand. So thank you for making it such that it totally makes sense, and someone that doesn't have any medical background like me and others to understand it. Could you go back 2 slides to the 6 companies that had shown exits or acquisitions? And 3 of those 6 had been exited during their CE mark trials or before they even came to market, right?
Yeah, the Symetis during CE mark, or they had sold some there. And then Corvalve, which got the most money, $750 million, they had sold about 2,000 valves after CE mark.
So what you're suggesting when you say a little company like us, we're not going to be permitted to complete the trials in Europe, it's simply because someone's going to write you a check before that ends up happening. Is that essentially what you mean there?
Exactly, because if we are the real threat to them, who is going to take a chance?
Yeah. Well, they're going to, it's not likely, well, I shouldn't say, I'll ask the question. It's not likely that they'll buy you and put you on the shelf. They're going to buy you and just blow you up and make it massively available with their balance sheet and their distribution.
Absolutely, because one valve with a durability can put all the other valves out of the market, at least for some time.
Yeah. So without disclosing things you don't need to disclose or should disclose, they have to be watching you, right?
Correct. And
Yeah.
we have been presenting in all these international conferences. Our medical advisor, Dr. Kodali and Dr. Williams, they have been presenting it, and they are on the consultation board with all the major companies. So
And
they are all watching us.
Yeah, and I'm imagining that Anurag's got a pulse on this too, which is likely to be part of his role. I'm not saying that it is. I'm just speculating. Super interesting. So we're going to run out of time, but that was super helpful. And thank you everybody for your questions, and thank you for a great presentation. And Samir and Anurag, thank you for being here. And Doctor, that was really extraordinary because it was so concise in a complicated area, but it totally makes sense. If you want to offer some closing remarks, and then we'll wrap it up.
Yeah, my closing remarks would be that this technology is not only here to stay, but it's here to expand. There's no stopping. Others will have to copy our patent if they want to produce a durable valve. And so the way I see it, we are on a very solid ground because of our two big companies that we have given license to. So we stand on a very solid ground, and it would be a benefit to those who want to invest and see us do the European trial, because in a worst case scenario, we can just give license to Brazil to do the trial in Europe, for example. So we are on a pretty solid ground.
And someone who would invest in the $8 million round would participate in all of that when the acquisition or sale or whatever happened.
Correct.
Yeah.
Correct. Royalties as well.
Yeah. Excellent. Yeah. So we're up against 116 now, or excuse me, to 216, 316. Sorry, I've got my time zones all fouled up here. That was super helpful. Thank you all for being here. Doctor, thank you again. That was just extraordinary. And thank you to all the Family Office Insights members and friends that have joined in today and shared with us the only thing you can't make more of, and that's your time. And Anurag, thank you for introducing the company. And Samir, I can see you smiling there. I know that's your picture, and thank you for paying attention and working away with us. We'll make sure everybody's in touch. We'll post it on the YouTube channel. And for now, until next time, thank you all for being here. Take care.
Thank you, Arthur.
Thank you, Arthur.
Bye-bye.